slightly changed. So if you signed up or know somebody who signed up and they have yet to have a link, go to our social media if you're not already here on Acute on Chronic Facebook, or you can go to my personal LinkedIn page, Rebecca Abraham on LinkedIn, or you can go to our Twitter, Acute on Chronic. So we're just going to give it about 5 to 10 minutes. So what we're going to do, we're going to have an educational talk, and then at the end, we'll take some Q&A. And thank you for coming. And it's nice. Views are going up, so that's delightful. But we're going to give it about 5 to 10 minutes. Hi, everybody. So we are going to get started, and we apologize. This is a new technology. So if you have a link, it actually sent you to be part of our guest panel, which is very strange. So just loop back over to Acute on Chronic YouTube, Acute on Chronic on Facebook, or you can also go to my LinkedIn at Rebecca Abraham, RNBSN on LinkedIn, and that should fix everything. Apologies for the reroute in, or if you're actually in the invited guest, you could hang there and just watch from there. So new technology, but we will begin.
Hello, everyone. My name is Ryan Buck. I'm a physician. I am the research director for Acute on Chronic. I'm also an assistant professor of medicine at Northwestern University. Rebecca, you want to go to the next slide? We've got our So Rebecca, she's the CEO and founder of Acute on Chronic. She's a former critical care nurse. She's also a certified cannabis nurse. She's got herself a certificate in global women's health leadership, and she's currently pursuing her nursing doctorate at Northern Illinois University. Like I said, I've joined Acute on Chronic as the research director in addition to my role at Northwestern as an oncology hospital. We're going to be talking today about how cannabis care can help seniors and older adults. So the big question that we get is cannabis safe? And the short answer is yes. It's got a much better safety profile than nearly any other kind of pharmaceutical medicine and supplement that is out there. There, obviously can be some side effects, but usually they are very short-lived. There is nothing that is long-term or permanent. Many studies have shown that there is absolutely no lethal dose of cannabis, so there is absolutely no way to overdose on it and die. There can be unpleasant side effects, but there's no lethal dose, unlike with many other medications. Sudden discontinuation doesn't lead to any severe withdrawal symptoms. If somebody is using cannabis, heavily for a long time, there can be some, minor withdrawal symptoms that people go through, but nothing, in the order that, say, people experiencing, alcohol, opiates, heavy use, things like that would experience. And in addition to a lot of pharmaceuticals as well, antidepressants and things like that, there's lots of things that sudden discontinuation can lead to a lot of kind of dangerous side effects. We don't see that with cannabis. And since the 1970s, there have been over 40,000 studies published on cannabis. So it is something, and every year thousands and thousands more. So it's something that we are learning more and more about every year, but we already know quite a bit about. So cannabis use as a medicine goes back a long time. The first kind of recorded use in history goes back to 2500 BC, where it's recorded in medical texts from China for use of various ailments. It continued to be used throughout Asia, Africa, Europe. It was definitely used, and we can see some examples here, extensively by doctors in the 1800s and early 1900s to treat hundreds of symptoms, pain, dysentery, migraines. There are many treatises talking about how its uses for a variety of substances. Even people saying it continues to be the best treatment for migraine. Like that. So that all kind of changed with the Marijuana Tax Act of 1937, where cannabis all of a sudden got tied up with absolutely no scientific reason, and then when they passed the laws scheduling controlled substances in the 1970s, it got tied into that as well, and there's really no good reason for it. In fact, in 1937, when this passed, the American Medical Association petitioned Congress not to do this. They said, if you take this away from us or make this hard for us to give our patients, how are we going to treat all of these different things? So if cannabis is safe, and the American Medical Association was in support of it, why is it illegal? Well, bias and money, as so often, unfortunately, is the case when things that kind of end up being politically motivated like this. cannabis. So a variety of very wealthy people, the DuPont family, Andrew Mellon and William Randolph Hearst, they all had a variety of business interests in paper, in oil, and a variety of things that hemp and cannabis directly competed with. And so they used their combined political might in order to petition the government, in order to classify this substance as illegal. And in addition to that, there were definitely people in the government that were willing to kind of take this on. So Henry Anslinger was part of the Federal Bureau of Narcotics and Hoover's FBI. And he was, more than willing to kind of take this on to kind of further his own political gains. There's a, pretty famous, feud that he had where he targeted Billie Holiday. She had a very famous song, that was very moving, very popular about, lynching in the South, and he absolutely hated it and hated that she was getting praise for it. And his, racism and his own, ambition kind of came out that he, viciously went after her and her, own private use with heroin, and then decided he was going to use the full force of the government to go after musicians and artists who were using drugs. And I've seen quotes that there is no one person alive that is more responsible for our current state of drug laws in this country and incarceration than him. Luckily, a lot of the stigma and propaganda is slowly changing, and I'm sure many of you heard that the government is, strongly considering, rescheduling cannabis from the current Schedule 1 status, where it is classified as a completely illegal substance and has absolutely no medicinal use, to Schedule 3, which is up for debate whether it should even be that, but is certainly a step in the right direction. So why does cannabis help? Why do we think it can help for a variety of things in anybody, especially older adults? So it has to do with the body's endocannabinoid system. And this is something that has kind of been discovered and kind of researched only more recently. I can tell you, like, I did not learn a thing about this in medical school, and very few people still do. But it is an incredibly important system. It is a system that is found in nearly all animals, even going down to invertebrates like mollusks, and it is throughout the body. And it is a system that is vitally important for signaling between cells, maintaining homeostasis, which is kind of like balance, within the body, and it affects just virtually any, systemic body process that happens. The endocannabinoid system is involved in regulating it. So this is a slightly simplified view. It is, as I said, a very, very complicated system, and it interacts with dozens of receptors kind of throughout the body. To break it down to kind of its two of its kind of most common and kind of most well-known sets of receptors are what we call the cannabinoid receptors, CB1 and CB2. The CB1 receptors are found primarily within the central nervous system and nerves. The CB2 receptors are more kind of diffused throughout most of the rest of the body and the immune system and places like that. And it's just an example of why we think that cannabinoids can work for a variety of substances. Is that for example, if you twisted your knee and hurt your knee, there's a variety of things that are going on there. There's the pain signaling that is being sent via the nerves to your brain, and then there's the local inflammatory response. And by modulating the effects of the CB1 receptors, you can kind of tamp down those sensations of pain that are being sent to the brain. And through interaction with the CB2 receptors, you can actually reduce the inflammation directly itself. And so there's a variety of ways that the cannabinoids and the endocannabinoid system can be harnessed for health and wellness. So how do cannabinoids affect the brain, and how does this factor into considerations for older folks? So the CB1 receptors are one of the most abundant receptors throughout the central nervous system and in the brain. They are densely located in areas of the brain that are associated with executive decision making, associated with memory, and associated with emotional responses. And all of these come into play, especially with issues with cognitive impairment, dementia, and things like that. And what do we know about the endocannabinoid system as we get older? So we know that that there's a decrease in those CB1 receptors that happen in the aging brain. So anandamide, this is one of the body's own endogenous cannabinoids. It's something not that comes from a plant, but just something that our body makes, to interact with this endocannabinoid system. So anandamide concentration peaks, in young adulthood or in puberty, and then it just kind of slowly goes down every year with age. In animal models, when they go in and genetically, when they remove those CB1 receptors, so they're no longer present in the animals, and study and sees what happens, it leads to kind of very accelerated cognitive decline. And when they look at kind of what actually happens in the brain, there's an area of the brain called the hippocampus, which is involved in memory and things like that. And there's a marked decrease in the size and volume of that hippocampus. And this is something that if you looked at the brain of somebody with Alzheimer's, they would have very, very similar changes. And this is uniquely kind of located with those CB1 receptors. If they do a different experiment and knock out those CB2 receptors, there's no changes that they see in the brain, but they see a variety of other systemic changes, such as osteoporosis, bone loss, and things like that. Again, just highlighting how kind of important this is kind of throughout. And what I hear sometimes when I talk about this, or when I talk about this with my colleagues who are not as familiar with the endocannabinoid system, especially when I talk about the benefits that it may have for folks with dementia and cognitive decline, they say, why would you want to give this mind-altering, confusing substance to older folks who may already be at risk or suffering from some of these issues? And what's pretty clear is that the studies looking at, does THC, for example, does it, affect your ability to think and to perform cognitive tasks? All of those studies are done on younger people and generally with pretty high doses of THC. They've not generally been done in older folks. And we do have some data, at least in animal studies, that THC in older mice seems to actually boost their cognition. And so what we have here is an experiment where they gave older and mature mice doses of they had a control group that they gave nothing to. They had another group that they gave THC to, and they kind of showed how did they do at the time it takes to solve the maze. And the older mice that were given THC every day, they learned the maze better, and they did it in a shorter amount of time. So the THC actually boosted the cognition in these older mice. And then when they, went and kind of did an actual anatomical analysis, they showed that kind of being exposed to this THC, increased the connections in the brain cells in the hippocampus, which again is that area of the brain that has a key role in memory. So how else can cannabis help for older folks? I just included just a variety of studies, here for that could be the example. So the first one was looking at folks with insomnia and chronic pain. And what the study showed is that medical cannabis did show a positive effect on maintaining sleep kind of throughout the night in patients that were dealing with chronic pain. There's another study here. One of our colleagues, Misha Kogan at GW, he's involved in this kind of RECODE program, and there have been some smaller case series showing again how cannabis might help with cognitive decline. And they published a number of years ago this larger case series looking at 100 of their patients, where they took this very personalized kind of multifactorial approach that involved nutrition, therapy, and cannabis, and showed that these patients improved on their cognitive scores. And then this last study this is something that's been shown in a variety of states or in a variety of patient populations, but that we definitely see time and time again that when patients have access to medical cannabis, they use other more dangerous medications less. So when states allowed for medical cannabis, and especially when they allowed for it in a way that allowed for there to actually be dispensaries for people to go to and purchase the cannabis, they showed a significant reduction of the opioid prescribing in those states. And so people were able to manage their pain with cannabis and did not need the opiate prescriptions. And again, I don't think I need to tell anyone the devastating effects of the opiate crisis and how dangerous of a medication that those are. And just another example. So this is a case report for us that we've had published. So this was an older woman, a woman in her 80s with Alzheimer's disease. Her family, brought her to us for issues with, managing some of what we call the neuropsychiatric symptoms of Alzheimer's. So this is the agitation, emotional dysregulation, sleep disturbances. She, in addition to the cognitive decline and the memory decline, she had been sleeping for large portions of the day and then waking up at night with severe anxiety, agitation. She was very, very difficult with caregivers when this would happen. She would uh, do a lot of agitated behaviors, yell, throw things, physically aggressive. It was becoming really, really challenging to help for them to help take care of her. They would do methods like redirection and distraction, try and get her to focus on something else, and that was certainly didn't always work. They tried a variety of kind of the traditional medications that we sometimes use, none of which helped significantly, which is not nobody in medicine would be surprised at this, that none of these medications seem like they work very well. So they came. They sought care from Rebecca, who developed a care plan for them that involved a variety of different cannabinoids: THC, CBD, CBDA, CBG. And through this kind of regimen of cannabinoids, the family reported that she was doing much better. She was sleeping through the night. She was not waking up with nightmares or waking. She was not having any more of those agitated outbursts, and they did not notice any kind of worsening in her mental status. That she wasn't reporting or seeming to be like high or altered in any way. And the only thing that they mentioned to us was that she kind of had dry eyes, and they definitely saw that as a huge, huge improvement in her quality of life and her ability to stay and be at home and for them to take care of her. It's been time. And so this is not, at all unusual, especially for older adults, in that, we know that many pharmaceuticals behave differently. Side effects that are more kind of minor or mild in younger folks have much more pronounced effect in older adults. And sometimes it goes so far that the effect of the medication completely flips. That there's, benzodiazepines or things like Ativan, Xanax, Klonopin. So these are used as anti-anxiety medications that calm people down and chill them out when they're feeling anxiety. And I'm sure any doc can tell you that they've got experience where you give an older person the benzodiazepine and they do not calm down. They become extremely agitated. The complete opposite effect you would expect. And again, this just reflects kind of the difference in the way that the brain function happens as we all get older. And something that happens as we get older too is kind of the amount of medications that we're on just kind of gradually accumulates as we get older. And there have been studies looking at that, 50% plus or minus of folks over the age of 65 are taking 5 or more medications. And what can often happen is that these medications can have side effects and drug interactions that lead to new problems that then have to be managed with more medication. So an example here, somebody's having a problem with sleep, so they are prescribed Ambien. The Ambien leads to urinary issues or incontinence at night, so they are prescribed Nablex to kind of mitigate the urinary incontinence. The Nablex causes confusion and delirium, and that delirium comes with agitation behavior issues, so they're prescribed Seroquel, which is an antipsychotic to try and calm them down. The Seroquel leads to disruptions in mood, and so they're prescribed Lexapro or an antidepressant in order to kind of help boost their mood. That Lexapro leads to insomnia, and the cycle starts again. And so often what primary care doctors and geriatricians spend a great deal of time on, especially with their older patients, is really trying to figure out what medications are absolutely necessary, which ones are creating more problems and they're doing good, and which ones are we just kind of, again, in this cycle where they may not need any of them, and we're just kind of treating this kind of cascade of symptoms with these medications.
So here's where I come in. The Beers criteria is something that exists for, it's a list created by many doctors, providers, nurse practitioners, nurses, a variety of folks get together, pharmacists, and they have this list. And it's dozens of medications that are recommended to avoid, if possible, in older adults to various degrees. 64% of older adults are taking at least one medication from the Beers list. And in Canada, there's actually a lower number of residents in long-term care facilities using antipsychotics, but that's still 30%. In the United States, it's actually significantly higher. So what is on this list? You'd be surprised. It's a lot. Antihistamines, so that's Benadryl. Antipsychotics, so that's your Seroquel, your Haldol. Famotidine, which is acid, so many older adults take that. Benzodiazepines, your Xanax, your Klonopin, Ativan, aspirin, NSAIDs, Motrin, ibuprofen, muscle relaxers, corticosteroids, hormones, and even more, some antibiotics like Cipro is on there. And what's not on there is cannabis, CBD, hemp, and Marinol. And Marinol is the synthetic form of THC that has been prescribed and FDA approved since the 1990s. And that is not on the Beers list. So cannabis really gives us the potential for better care and improved quality of life for older adults. And why? So I have some examples of treatment mitigation strategies we have, particularly for confusion, sundowning, dementia, delirium. And you might say, but I am either currently an adult or I am an older adult and I am not at risk for Alzheimer's or Lewy body dementia, none of those things. Unfortunately, anybody, and I mean anybody younger or old, but particularly this is a risk in older adults, anybody over the age of 65, you are at risk for any sort of ICU delirium, any sort of facility-related delirium, or even post-surgical delirium. And it truly can happen to anybody. And so what do we do when that happens? None of our treatments are truly humane. They're actually pretty terrible. They're expensive, they're harmful, and they're traumatic to both the patient and the caregiver. So I have an example of restraints. This happens to many people after they even have one major surgery, but can continue for days if you're hospitalized long enough. And so you could see how that could be traumatic. And then we put patients sometimes in the hallways when folks are confused for a variety of reasons, even related to medications. We will put them in the hallway so nurses can watch them better. As you know, facilities and hospitals aren't really staffed that well. And so to try and protect that patient, if their family can't be around, we put them in the hallway. However, that's very stimulating, it's very noisy, and also that could be traumatic too. Because you're kind of hearing the sounds of other patients and what's going on with them. So that's not really good care or relaxing, but it's kind of a necessary thing that we've had to do in the past. And then I've put a unhappy face just to protect this patient, but this was actually international news. This is an example of what happens when we give patients the antipsychotics. This was a patient in Canada who was actually given an antipsychotic for over 14 hours a day to control their symptoms. And as you can see, they are slumped over, they are unable to talk. And how Americans actually view what we call a nursing home or a long-term care facility or even a rehab is like patients like that. And the reason is because in a lot of facilities, the choice is to take the antipsychotic or to get discharged and be forced out of your facility. So when you imagine this very grim picture of older adult life, institutionalized and in facilities, it's actually because of how we've been managing patients, because there have been no good treatments for people who are acutely confused. So that means they don't have any chronic illness that would relate to confusion forever. Even if it's brief, this kind of ends up being the state of the patient. So this is something we want to avoid, which is where the potential for cannabis really comes in, because obviously if we could not do those things, we want to. Canada has taken a lot of really good initiatives to avoid antipsychotics. They make you go through a lot of documentation. There's a lot of monitoring and checking to see that these aren't prescribed kind of as they are in the United States, very off-label. and it's not good for the patient. So side effect comparison, cannabis versus, let's take NSAIDs, right? NSAIDs are something pretty common that most of us take and don't really think about. So all cannabis formulations, and I'll go through the various kinds, the only side effects are dizziness, low blood pressure, and sleepiness. Those are what we can confirm. We'll talk a little more about the research. There's some question about long-term effects, but I want to just make a note that there have been millions of dollars spent on researching the negative side effects of cannabis. And this is what we've actually come up with some, like, perhaps other long-term effects. But remember, those studies were done retrospectively, self-reported, from an underground market of substances that we didn't actually know what was in them, and mostly from recreational users, not from medical patients. So those, we know that true long-term studies are likely going to show us something very, very different. So then we take THC only. So I'll talk about this more, but we spend 90% of our time talking about 3% of the cannabis plant. So there's more side effects with THC. Euphoria, which could be a potential benefit, not necessarily a side effect, but increased heart rate, increased body sensations, increased appetite, nausea and vomiting, and then anxiety. And that's all dose dependent. Now, if you look at NSAIDs, something many, many, many people take, particularly older adults, side effects include death, stomach bleeding, kidney failure, liver failure, increased risk of heart attack and stroke, headaches, indigestion, increased blood pressure, and so on. So as you see, you take NSAIDs, you get indigestion, then you're put on Pepsid, which is on the beers list, and as you can see, this cascade gets bigger and bigger. So where do you get cannabis education from? So far, there's company like ours at Acute on Chronic where we have cannabis nurses and cannabis doctors and cannabis pharmacists available. But most doctors, like Ryan said, are not educated on this. Nurses are not educated on this either. And then most people think you could just go to the dispensary and get your healthcare information, but no, actually state laws prohibit dispensary workers from saying really anything related to healthcare. So that really leaves people going to the internet or friends and family. And it's just something people aren't educated in. And we are specialists, and there are other specialists beyond us. So if you're thinking more and more, and you will probably as this talk goes on, about considering cannabis as a supplement to include in your health and wellness regimen, we are going to tell you how and why you should choose a specific cannabis expert on guiding you through that. So if there has been prohibition, and there's still prohibition, how do we get evidence? So we do have studies, as Ryan talked about, more and more globally, thanks to countries like Israel, South Africa, Australia, are producing more and more international studies. But then there's a piece of education and research that we kind of leave out, gender-based actually. So nurses have always used something called practice-based evidence. In healthcare, we talk a lot about evidence-based practice, but that takes years to get, 30 years after the initial research is done. And that initial research is based on randomized control trials, which won't work for cannabis or actually any other botanicals, because pharmaceuticals are synthetic and you could remove and add variables in. Cannabis, we know that it's going to be a layered approach to care. So that model won't work, but practice-based evidence is something that nurses have been using for the last hundreds of years. It's how nursing was founded. Florence Nightingale did practice-based evidence. She cleaned soldiers up in the Crimea War. She found that keeping wounds clean decreased infection, and then we studied it, right? Nurses do this all the time, and we did it with G-tubes. We put Coca-Cola in the G-tube. We know it wouldn't hurt anybody. We tried it. We don't have to wake a resident up at the middle of the night. And then later we studied it to see that it was an effective way to clear a G-tube without having the patient go to surgery or withholding meds. So practice-based evidence is something when we know something has a pretty high safety profile and we use it, we then study what happened later. So this is the way we're kind of building knowledge as we go for something like cannabis. So what is cannabis? How do you use it? What kinds? What next? So cannabinoids, I said THC was 3% of the plant, but we spend 90% of our time talking about it. And as you can see, pretty true. There's 162 cannabinoids. And a big question we get often from people is, do I have to get high? The answer is no, absolutely not. And then the second question we get is, what else is this stuff? So these other cannabinoids are really, really great and therapeutic, most like, as we perhaps from the research. So there are many different options to use for your health and wellness goals, not just THC Delta 9. So I'll just begin on the two cannabinoids you've probably heard the most about and that are the most abundant in the market, THC. So this is the only truly mind-altering euphoric substance in the cannabis plant, but it is very effective for acute symptoms like, as the research says, but TBD. We can't say anything officially, of course. And euphoria is not necessarily a side effect, but something that we should be embracing more often. CBD, not altering at all, little to no side effects beyond dizziness, sleepiness, no withdrawal symptoms, and could help people tolerate THC. And so think of cannabis like a symphony. You can't take one cannabinoid that works, like CBD, and some people do report an effectiveness from that. But a layered approach is oftentimes better, and think of it like a symphony where you could have CBD like a violin. It's a very beautiful song, but when you add other components, we see a little bit of a better effect, like a symphony. So when you have that whole symphony, the song sounds better. And CBG is the cannabinoid I love talking about most. So CBG is the stem cell, or it's also slang known as the mother of cannabinoids. We see this work really well in older adults, and it actually exists not just in the cannabis plant, it actually exists in other flowers. So if you're somebody who can't take the risk, there's some medications, and we'll talk about that you can't use cannabis with. CBG can actually be found in other plants, and so can some other cannabinoids. Like hops are a cousin of cannabis. Echinacea is a cousin of cannabis. You could even find CBG in flowering plants. So if you want to stimulate your endocannabinoid system, you can actually do that in a variety of ways. And CBG is this great cannabinoid with very little side effects and a lot of, hopefully, potential use in the future. Terpenes. Terpenes and flavonoids are the essential oils of all plant life. It's in oranges, it's in lemons, but those scents have a therapeutic effect. We just don't study them a lot because of the pharmaceutical model that we exist in, and it's not frequently taught to doctors or nurses. But for example, there was a study in Germany that showed linalool, and that's the scent of lavender, is actually pretty effective in controlling anxiety when compared to Ativan. So we know these things have therapeutic potential, and they are in cannabis. So sometimes when you're picking a particular product or strain, we do look at your terpene and flavonoids to see what would work best. And then routes of administration, there's 13. A lot of people assume cannabis is either smoking or using gummies, and it's actually so much more than that. And I'll go through them and the pros and special considerations for older adults. So tinctures, oil sprays, those of us in cannabis nursing and cannabis medicine, tinctures are talked about a lot for older adults. But I will say it may not always be the best course of action. So some benefits of it, accurate dosing. On the true research side, we actually have some solid clinical research that comes from the FDA approved pharmaceuticals, and it's fast acting. Special considerations for older adult populations: if you have somebody who is confused or doesn't really want to take anything, this has a poor taste, and you have to hold it under your tongue for about 30 to 90 seconds. So this might not be best for somebody who's not really, excited to take anything that tastes bad, or a patient or family member or resident of your facility that you already have to kind of bury some medications in applesauce. So another route of administration is inhalation. And so we think of this as smoking, vaping, and inhalers. Sorry, my S went down there. Inhalers are coming. I know there's a lot of people trying to develop this. So a lot of people poo-poo smoking and vaping. And I will say for the older adult population or anybody with a really big chronic illness that's affecting their quality of life, and will likely affect their mortality, it's a little more nuanced than that. If there is somebody who is in their 80s or 90s and they're just focused on quality of life, inhalation might actually be a decent option for them. If they're not eating and they just want to enjoy life, inhalation is a way to do that and to decrease pain, and it works fast. For symptoms like nausea, this is probably a better route of administration than other things. Like if you're nauseous, you probably don't want to have an edible. Special considerations, we do want to avoid this with anybody who has had chronic lung issues. We want to avoid with prior tobacco use, like we don't want somebody who's quit smoking to begin smoking again. And then of course, housing considerations. Public housing does not allow cannabis use. Some apartments, some HOAs of condos may not allow for cannabis use. Also, if somebody's in a facility, either temporary or long-term, this could be a barrier. So edibles. This is the most popular one that patients ask for. They ask for the gummy. But the downside of the gummy is you really have to pay attention to dosing because they could be strong. Why are they strong? The cannabis molecule actually changes up in the liver. It changes from, if you're a chemist, you'll be delighted at this. It changes from THC delta 9 to THC delta 11, which is a little stronger. Benefits, long-lasting effects. The strong helps with chronic symptoms sometimes, and it tastes good. Special considerations for older adults is it's easy to administer, much easier than a tincture or vaping. You have to be considerate of ingredients, allergies, diet. You don't want to be giving something very high in sugar to somebody who has diabetes type 2. You don't want to kind of make them long for gummy bears. Another issue we see that has been under-identified is there are many folks who don't metabolize edibles, particularly Caucasian women and folks of Asian descent sometimes are missing the enzyme that breaks down edibles. So there are some people who can eat edibles and never feel a thing, and there's nothing we could really do to help them, so they would have to pick another route. Topicals and transdermals are another route of administration. They have a chart here where the topicals is a really great entry level for older adults because it doesn't go to your bloodstream. And it's pretty effective from some of the, just some of the one-off patient care N of 1 that we've seen. The topicals are a really safe choice. You don't have to worry about them doing anything or even mixing with various medications because it stops right there at the epidermis. But the transdermals, those are patches, and there are some gels that now are transdermal, but those do go to the bloodstream for circulation. What's nice about transdermals, if you hate how they feel, you could take them off within 20 minutes. What's nice about these two is they are long-lasting and they can be applied by a caregiver. The only other route of administration not included here, because we do need more information, is actually suppositories. For women with any sort of long-term vaginosis as we age, there's vaginal atrophy. Those suppositories might locally help. We don't know if they're local or systemic, and there's also rectal suppositories too. I just caution, don't go to suppositories until you've checked with a healthcare provider that you can use suppositories, particularly if you're immunocompromised or if you're on any type of anticoagulant or if low platelets or bleeding issues, you could cause a really bad infection by doing that route. So always check with a healthcare provider before doing that. So our approach is nursing guidance. How did I even come to this company? Why do I do this? How did I become a cannabis nurse? So I was a critical care nurse, and for decades, even since nursing school, I've always seen patients say, I have a medical card, but I don't know what I'm doing. Or I heard cannabis can help, but no one can seem to tell me how. So nurses guide all the time in a variety of ways with physician oversight, but not necessarily, hand-holding us the entire way. And cannabis and nursing actually works really well together. So cannabis nurses, when we get involved with recommending, and safe education and teaching the patient, we actually see better results. So we do assessments, goal setting, we provide supportive care, nursing interventions, and have that therapeutic relationship. And that therapeutic relationship is really key because if you have been going to the doctor over the last at least 20 years, you have seen that your therapeutic relationship with your providers has probably lessened. Not at the fault of the provider or your nurses. It's just kind of the way the system's gone. You're getting less time with your nurse, your doctor. You're not really getting a chance to see anybody. And at Acute on Chronic and nurses in general in our own practice, we provide that human touch and therapeutic relationship back in. So you feel supported and you feel listened to. Why do you even need a cannabis nurse or clinician? Well, cannabis is very different than pharmaceuticals. With pharmaceuticals, you go up and you hit a peak, and then we either know it works or it doesn't. There's a lot of standardized dosing. In cannabis, everybody's different, and we're looking to get the medium dose peak effect. So a little bit challenging, and we have our own special ways to get there. But it's not as clear cut. It's just going somewhere and, finding cannabis and hoping you get right to the middle. Can you just do this yourself and do it in secret and not tell anybody? You could, but you shouldn't. So like we've said a couple of times during this talk, cannabis is safe. What's not safe is the other pharmaceuticals. And so drug interactions and side effects to pharmaceuticals are a problem. And so cannabis does interact with over 100 medications. Now, this doesn't mean you can't use cannabis. It just means we have to be aware of it and tell you how to mitigate problems and what to look out for. There are 2 medications that you should be very, very mindful of. And there are some cases where you should avoid cannabis. One case for sure is Plavix. If you have had a cardiac or any sort of vascular intervention within a year, you absolutely should not be using cannabis. And this research is fairly new and fairly unknown. We recommend avoid, and that's because it decreases probably the amount of Plavix, and that's something we don't want to mess with. And then actually, CBD is the thing that interacts with drugs more than the other cannabinoids. So don't just buy CBD willy-nilly, definitely double check. The other one we always caution about, particularly in older adults, is warfarin, also Coumadin. And the reason is it could increase the potency of that to make you bleed easier. So if you were to trip and fall, you could bleed even more. So those are the 2 really ones that we're very careful with. But know that even antibiotics, lots of pharmaceuticals interact with cannabis. Most of the time, it's a scheduling and safety and education thing that we could mitigate. And actually, sometimes there's a synergistic relationship, sometimes not. And so that's why it takes the skill of a cannabis clinician to do this, particularly if you're on more than one. So self-titrating is something your cannabis clinician will teach you how to do. Similar to insulin, again, there's no one-size-fits-all dosing, much like what you eat and exercise and what your day is like. If you were taking insulin as a diabetic patient, this is the same for cannabis. So we teach patients how to self-titrate. And so this is just an example of what self-titrating is and what we teach the patients. But it's truly, it might vary day to day. It might vary on your circumstance. And we give you that robust foundation of how to do that and how to dose yourself. What's nice about cannabis too is it gives the patient back autonomy. A lot of things in medicine are do this or don't. In cannabis nursing and cannabis care, there is a lot of nuance and there's a lot of autonomy given back to the patient. So facility and caregiver considerations, this is a question we get a lot. There are some facilities now opening up to cannabis, which is really great. So it really depends on the administration and the director of nursing. And it depends on states. Some states there's delivery. Some states like California, nurses are allowed to give cannabis, and in hospitals even under something called Bryan's Law. And what we have seen and the research indicates is when patients utilize cannabis as a supplement to improve their health and wellness, we see decreased pharmacology and cost savings. And we see that autonomy given back, which empowers the patient. There's a lot of studies where when patients feel positive and empowered, they actually have better healthcare results. So if you have a family member or if you're yourself living in an independent or assisted living, know that it's not a hard no, that it's literally just a conversation with your administration. And then there has been no reported removal of any sort of CMS funds for facilities utilizing medical cannabis. It just depends on the facility and the rules. So safety considerations for folks deciding to use cannabis. So the one labs we really look at are liver enzymes because everything is metabolized in the liver. So we just want to be sure that you're not going to boost your liver enzymes, which is a sign of liver injury. Sometimes CBD in particular at high doses can overwork the liver. And then we want to check your INR, CBC chem panel, just to be sure everything's fine. The INR is if you're on those blood thinners to see that your blood thinning isn't going up. Checking for drug interactions and adjusting doses is important. And then if you decide to use any kind of cannabis, you want to be sure to tell your surgeon or anesthesiologist if you are using cannabis, yes, even CBD, because it can alter that sedation. And if you know of a surgery, we recommend you hold your cannabis at least 48 hours prior to surgery and let the team know. Now, that is with an asterisk, personal safety first. If you are in an unfriendly state, if you feel like it is not a safe place, I say always just say CBD and the doctors will adjust. But if you think you're at risk for any kind of medical bias, you could always say you drink a lot of grapefruit juice. It interacts on the same receptor. So you could keep yourself safe at the same time. Hopefully one day we will get to a place where I won't have to add that caveat to this talk. Other safety tips: use your first dose at home with THC for at least 12 hours without any obligations. Do not drive during this period. And you may be aware of more sensations. And then staying hydrated. Like we talked about, the side effects are dizziness and sleepiness. And that reason is because cannabis vasodilates. So it opens up your blood vessels very, very wide, but this can have a very dehydrating effect. So those side effects can be mitigated with a lot of hydration. Other safety considerations. The other reason to work with a cannabis clinician is 88% of CBD products in particular are fraudulent. It's mostly some sort of oil, olive oil. It could be, and then out of those 12%, sometimes there are heavy metals, fungus, pesticides. So you always want to check with the cannabis clinician. And in lieu of that, there's something called COAs that have all the information about the product. And you would be able to test and see if anything pops up there, like arsenic sometimes comes up in the counterfeit products and some bad actors. Farming technique does matter a lot here. And then always look for third-party lab tested products. A really big note for hemp and CBD, Delta 8 is very nuanced. I always recommend try to avoid this unless you are in a state that does not allow any medical or adult use cannabis. This is, again, where a cannabis clinician comes in. We want to be sure that we can get it as safe as we can. It is a synthetic. Synthetics work different than the plant. This we know. We want to be sure that the solvents aren't dangerous either. So we do try to avoid this, but in some cases, we work with the patient if there's no other options. Avoid at all costs something called HHC. This is really popular in Europe, but definitely avoid this. If you see this, it could be sold in supermarkets or gas stations. It is a synthetic cannabinoid. We have no idea what this does to the human body, so avoid. THCO is another one you could find in vapes in gas stations and some, unauthorized cannabis clubs. It has really bad effects if you inhale it on the lungs. It causes really bad inflammation. We have no studies on the human body. Avoid at all costs. THC Delta 10 synthetic. Again, not research, no idea, avoid. And then this gets a little nuanced and very hard to tell, but THC Delta 9 synthetic. So there are people who are taking CBD, throwing a bunch of chemicals into it, changing the molecular formula, and making that something different. We recognize, please use the regulated market as much as you can, and folks that are looking and doing COAs and regulations. There's a sneaky way that companies are getting the THC Delta 9 through hemp, and if it's organic, that's actually safe in the same product you see in the dispensaries. The difference, you just want to avoid the synthetic, and it's really hard to know if you're a lay person. So please use the state market if you can. So qualifying diagnosis is States vary. This is a really robust list of all of the different disease processes that might be able to qualify for a medical card in certain states, but it really depends state by state. There's some states just have 3, and then there are states that have about 100, and then there are states that have an open book, so it really depends on where you live. There are some other fantastic free resources. Project CBD, the Society of Cannabis Clinicians, the American Cannabis Association, one that's not on here, Cannabis Nurse Network. PubMed is always great, free resource to the public of studies. And then Cannakeys, should you want to pay for a database of cannabis research, you can, and they're a wonderful source. There's always lots of books out there, but that's us, and we will take Q&A. I see some things like rolling in through, but I will at least stop sharing and see if we have any questions to answer. Let's see here. See contaminants. I'm going to see on anything, and feel free to just put in the chat if there's any questions. Otherwise, we are right at an hour, and that is our talk on seniors and medical cannabis and cannabis in general from our view. And so we'd like to thank Curaleaf for sponsoring this event. And yeah, and we're happy to do these talks all the time. If you're a physician, a patient, or somebody who's just mildly interested in knowing what cannabis can do as a supplement, you could always reach out to us. We're Acute on Chronic, and that's www.acuteenchronic.com. And all of our channels are essentially Acute on Chronic on everything. I believe TikTok is Acute RN 420 or Acute Chronic RN. Instagram is Acute Chronic RN 420. TikTok is Acute Chronic RN, and then everything else is Acute on Chronic. So is the PowerPoint available? It is. So, and we're probably going to do clips of this and share it all over. But yeah, reach out to us for more education. We're also happy to talk to your doctor and nurses and healthcare team and family members. So never hesitate to reach out. It's something we do quite often. So if there are, I don't see any questions. Yes, yes. So technically, if you feel dizzy, it's because you need to drink more water, and that usually mitigates it. So thank you for coming. And if you have any questions, you can email us at admin@acuteenchronic.com. Thank you.